So good afternoon. I think we were going through thyroidism and we have seen various here we have seen various diagnostic parameters and what is to be done in that case. These are the cases, these are the diagnostic parameters we have seen, and on that basis we have seen that these various commandments, that what is to be done, what are various signs symptoms are there. There are some algorithms are there which I think we were about to see. That is, you measure the TSH. If the TSH is elevated or there is a normal TSH. If there is a elevated TSH, then go for this T4, this one. If it is normal, it's fine. If it is low, then we call it as a, this we'll call it as, if it is normal, then we call it as a subclinical hypothyroidism. That means although it is not having any sign symptoms so far, but it can be there. Then go for check this TPO, the enzyme which is important in the synthesis. So if it is there, then it shows TPO positive, then go for T4 replenishment. If not, then go for the just annual follow-up, check it whether it is increasing. Okay. Then if it is low, the measure is low, then what you will do is this, that means there is a primary hypothyroidism is there. Again check this enzyme, okay, thyroid peroxide, and if it is plus, it is more, then it is a Hashimoto's disease, then we will treat accordingly. If it is less, it is negative, then there is some other reason which has to be checked. If it is a normal TSH, and so TSH initially it was elevated, in earlier case it was more. If it is TSH is normal, then check whether it is because of the pituitary reasons. Then there is a pituitary, there is no pituitary, then there is no test is required, only go for follow-ups. If it is pituitary, then measure again this total T4 count. If it is low, then we call it as a to increase the pituitary sick euthyroid drugs effects, because there are drugs which are affecting the pituitary gland and reducing it. If it is normal, then there are no tests are required. So if TSH is normal and T4 is normal, then everything is fine. In case of hyperthyroidism, this is another algorithm we can have. There are 4 conditions are possible. TSH is reduced, but the total T4 is there, is increased. Then we call it as a primary thyrotoxicosis. That is a very clear feature of the Graves' disease. Then that shows feature of Graves' disease. Just a minute. Hello. हाँ. सध्या मग एक काम कर, एक तुमचे 5-6 विद्यार्थी आणि बी फॉर्मचे 5-6 विद्यार्थी असा एक ग्रुप बनव. खूप गर्दी नका करू त्याच्यामध्ये, आणि ते तुम्ही नंतर कन्व्हे करा त्याच्या वेगळ्या ग्रुपला. बरं बनव, नाही तर मग, कारण आपला आता कॉमन सुरू आहे ना, तर एकच ग्रुप बनवा कॉमन HAPचा. हां, फॉर्म डीला पण काढा आणि 3-4 जण राहावं त्याच्यामध्ये, आहे ना. जर घेत तुम्ही सगळ्यांची घेत असेल तर सगळे घ्या, नाही तर मग दोघांची 10-10 रिप्रेझेंटेटिव्ह घ्या, काहीतरी एकच ठरवा. तर मग सध्या सिलेबस कॉमन आहे ना, मग त्यांची सगळे तुमची सगळे ठेवा. चालते, ठीक आहे. हां. Then next is case where TSH is less, and then this T4, that is tetraiodothyronine is normal. In that case, what you will do is go for measurement of this T3, that is triiodothyronine. If it is high, then we call it as a T3 toxicosis. If it is normal, then we call it as a subclinical hyperthyroidism. And then these all are the diagnostic features actually, which I think we have seen it. And then these are the various causes of thyroidism, hyperthyroidism. That is Graves' disease, diffuse toxic goiter, toxic phase of acute thyroiditis, toxic single adenoma, pituitary tumors, molar pregnancy and choriocarcinoma, where there is increase in the beta human chorionic gonadotropins, metastatic thyroid cancers. Then there is a struma ovary, that is dermoid and ovarian tumors, thyrotoxicosis factia. These are various diseases in which there is an increase in the thyroid levels. And these are the summaries of various hyperthyroidism conditions. Example is Graves' disease, then multinodular goiter, adenomas, thyroiditis. In that, how it looks, it is given. In what age it is causing and how, what are the features, are there pain, yes or no. Then various anti-thyroid drugs we are comparing, and this you can get it from pharmacology. What are various drugs, whether it can be used in various condition. Example, methimazole is very potent, while this PTU, we call it as a propylthiouracil, is comparatively less potent, or duration of action, it is long acting. This is therefore it has to be given twice a day. This has to be given 4 times or 3 times a day. In pregnancy, methimazole is contraindicated. How this can be given? Mechanism of action in pharmacology, you might have seen it is iodination coupling. Here also same. T3 to T4 conversion, it has no action, but yes, it can convert it. Adverse effect, trashes neutropenia. Here it causes more neutropenia comparatively, and these are the doses. So whenever the cases are there, treatments are there. FNSC, I think I told you earlier. I feel that we have seen this slide also. So this is how we are going for that. When there is a nodules in thyroid is there, because of that either TSH can be normal or low. If it is low, then go for this strontium 99 nuclear scan, and that causes increase in the temperature, so we call it as a hot nodule, or it can be called as a cold nodule. If it is cold nodule, then we go for FNSC, that is fine needle aspiration cytology, that is, or US guided biopsy, we go for that and check whether there is a malignancy, there is a suspicious or follicular situation is there, whether it is a benign tumor is there, cyst is there, or there is a non-diagnostic, then we can repeat FNSC or we can go for biopsy. And these are normal percentage of this, and accordingly we understand. So these are various diagnostic feature and various these thyroid problems which can be there. Now we can think about, once we understand about it, then we can have various treatment portions available for that. And we have classified it. What is this overt hyperthyroidism, subclinical hyperthyroidism? We have seen it. Now what are the treatments for that? When it is over hyperthyroidism, where there is a Graves' disease, they should be treated with any of these following modalities. That is anti-thyroid drugs. We have seen 2 anti-thyroid drugs just now. One is methimazole and second is propylthiouracil. And we have compared both just now. Or go for radio iodine therapy, that is radioactive iodine therapy we are using, that is RAI therapy. Or go for the thyroidectomy, that is removal of thyroid gland. This is the treatment for thyroid, that is Graves' hyperthyroidism. In that case, patient should be informed about side effects of these drugs, that necessarily informing it about various drugs like rash, jaundice, then stool color, acolic stools, that is and dark urine is there, arthralgia, that is pain in joints, abdominal pain, nausea, fatigue, fever, pharyngitis. This can be the signs. But then patients having overly this what we can say thyroid increase should be treated with that is tumors are there or nodules are there, that is multinodular goiter is there. that is thyroid multinodal goiter or activities are there in this thyroid, it should be treated with the radioactive iodine therapy or thyroidectomy. Long-term low-dose treatment with methimazole can also be approved. Hello? हाँ नहीं ना नाही नाही चालतं हा हा आरामात काही नाही ओके थांबा ना मग सगळं एकत्रच जाऊ तिघं जण आपण हां तेच ना मग ओके एकत्र जाऊ आपण फक्त एक दिवस थांबू आपण परवा थांबू ना परवा जाऊ हां ओके नाही सगळं एकत्रच करू तेव्हा आपण नाही तुम्ही पण नवले सरांना सांगा मी पण सांगतो सगळं एकत्र करू हां 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 नाही सगळेच ठरवू आपण बस संपलं आजच संपूर्णच टाकायचं त्याला चला ओके चला हां बाय So what we have seen that these are the treatments which are there. On a long-term low-dose treatment with this can be there, like methimazole can be appropriate. Then when there is a subclinical hyperthyroidism, subclinical means as I told you earlier where the
sir presentation नाही दिसत आहे.
अच्छा थांब. Then next is subclinic. This is subclinical hyperthyroidism. With all this diagnostic we know that it is there, then simultaneously one can go for ECG, echo and bone mineral density assessment which are having this subclinical hyperthyroidism. The treatment should be considered in patient with the subclinical hyperthyroidism who are either elderly, that is which are having age above 65 years, or with comorbidities. Comorbidity means simultaneously any other disease is there like cardiac disease or osteoporosis, or TSH level are less than 0.1 microunit per liter. Then it should be decided on the etiology of the treatment, and simultaneously the supporting treatment for cardiac disease and should be there. Then next is overt hypothyroidism. The treatment for that is a levothyroxine, and that is the most important treatment. It is only treatment we can say it is there. It should be continued. It should be given best taken at the empty stomach 1 hour before breakfast or bedtime, 3 hours after the last meal or day, and it should be separated from other interfering medications because absorption can interfere. Levothyroxine replacement therapy can be started initially full replacement or partial replacement with slowly gradual dose increments. This dose titration word is very, very important in therapeutics. That is when we are using dose, then we have to, sometimes the dose may be more, sometimes dose may be less. It is not appropriate, it is too much, then we have to reach to the proper dose, simultaneously observing various signs. So using serum TSH as a goal, that is we want to, so when serum TSH is reaching to the normal level, then that dose of levothyroxine is proper. Suppose if you are giving levothyroxine in too much dose and it causes decrease in TSH, that is not acceptable. Or if it is you are giving it too less levothyroxine and it causes increase in the TSH level, then again it is not acceptable. So we have to see it in that way. And the free thyroxine level should be measured in the secondary hypothyroxine. In hospitalized patient, The enteral administration is contraindicated because if from the if it is patient is unconscious or cannot take the tablets or because of one or other reasons, then intravenous can be given, which is 75% of the oral dose should be given into it. Then next is subclinical hypothyroidism is defined as the serum TSH concentrations above the statistically defined upper limit of the reference range. When the serum FT4 is within the reference range, we have seen all these definitions, subclinical, etc. So in that case, again we have to check anti-TPO antibodies. We have seen earlier TPO, that is this thyroid peroxidase enzyme and antibodies against it. If there is antibodies are there, then it will help in definition of the risk of progressions. Then there are problems like thyroid nodule goiter, and accordingly we have seen it radio abnormality, radiographic, that is X-ray, we can see whether nodules are there, and in that accordingly we can go for either surgery or various such treatments. Then one of the very awkward or various problematic situation is called as a thyroid storm. It is again clinical diagnosis has to be done. Various tools are there, that is BWPS and JTA, that is Joint Thyroid Association tools are there, and they are used to a diagnosis. But the another one is the scorings are there, various parameters are there on that BWPS, and accordingly we can go for that. हाँ बोलिए मैडम. हाँ मेरे रूम में हूँ. Hello, can you hear? Can you hear? So what we are having various thyroid, these are the important conditions. Thyroid storm is important, and go for the treatment with high dose of PTU, that is propylthiouracil or methimazole. And then I told you to read the impact of thyroid on ANS. What is the impact of thyroid on ANS? This is in physiology. So go for use of either this propylthiouracil, that is PTU, or MMI, beta blockers, glucocorticoid, and Lugol's iodine. These are the various treatments which are there. Again, as I told you earlier, what is the impact of thyroid on ANS is very, very important, and accordingly what will be the signs. This is I gave as an assignment, but I have not seen anything in that. You can go through it, what is the, so that you will able to understand the sign symptoms comparatively in better way. How thyroid impacts ANS, the change in the thyroid makes what changes in the ANS activities, and accordingly you will find the symptoms are matching with that, and accordingly what treatment is there. Again you will realize that then why beta blockers we are using, why glucocorticoids are using. Okay, Lugol's iodine is a iodine there, that is iodide, if you remember pharmacology of it and how iodide can block it. Okay, so these are the various activities. Then this fluid replacement and parenteral, what we can say, replacement considered in severely or rapidly deteriorating thyroid storm, or when the contraindication to started multimodal therapy, then we can use it. All the patients with thyroid storm should be early definitive therapy with radioactive iodine, because it causes destruction of the thyroid gland. And the patients with the large obstructing goiter, early thyroidectomy should be considered instead. Then another disease, another problem with that is a myxedemia coma. Intravenous hydrocortisone 2 milligram given. Stat means immediately. When then 100 mg 6 to 8 hourly should be there. Myxedema is severe edema is there, and this hydrocortisone is an anti-inflammatory agent which will reduce this inflammation. Then give this levothyroxine 200 to 400 microgram followed by 1.6 microgram per kg per day, and it should be given thereafter. Alternatively, oral levothyroxine can also be given as 500 milligram loading dose followed by maintenance dose. Now we have discussed this loading dose maintenance during pharmacokinetics and pharmacology. Will not go for what is the pre or peri-operative management, that is how the surgery is there, what is there. But yes, in that we can give at the time of surgery we can give this methimazole or PTU, beta blockers, iodine, glucocorticoids. They are also given simultaneously to control this. So treatment is also being done in same way earlier in thyrotoxicosis we have seen. The patient with the risk factor for hypothyroidism or those who exhibit symptom of hypothyroidism should be screened. And in mild hypothyroidism, particularly having subclinical hypothyroidism, surgery should not be postponed. So this is what various conditions. Then subacute thyroiditis, that is decurrence thyroiditis. Thyroiditis is an inflammation of thyroid gland. It should be suspected in all patients who present with the painful goiter. ESR, that is erythrocyte sedimentation rate, or C-reactive protein should be measured, that gives sign of inflammation. Elevated erythrocyte sedimentation rate and CRP is suggestive of subacute thyroiditis. Non-steroidal anti-inflammatory drugs are the first line therapy and should be used for the patient with the mild symptoms. Acute supportive thyroiditis, the patient who have ultrasound findings suggestive of abscesses or that, go for the culture testing, and if there is microorganisms involved, then go for antibiotic treatment. Okay, hypothyroidism and pregnancy, then give the thyroxine to this pregnant female so that it is not there. So LT4, that is thyroxine or levothyroxine, is given in these patients. Pregnant women with positive TPO antibodies, LT4 is recommended is TSH is above the pregnancy specific reference level, and again levothyroxine is the only treatment. So actually in this topic you will find that number of treatment options are very less. If it is hypothyroidism, then you have only the that is levothyroxine is a treatment, and iodine supplement if it is simple iodine, simple goiter. And if it is toxic goiter or if it is hyperthyroidism, then you have got anti-thyroid drugs like iodide or this methimazole or propylthiouracil. Actually these are only the treatment, and that too again condition based. We have seen about that, their potency, their beneficial effect and toxic effect, and on that basis we can select on the conditions required as required it is. Okay. So if it is transient thyrotoxicosis is there in pregnancy, then give supportive therapy, rehydration, hospitalization, because the drug which are there, that is methimazole, it's causing, it is affecting the fetus, so it is not used. Even propylthiouracil should be used with caution as far as possible. It should be controlled with all other things than direct treatment. Then postpartum, that is after delivery, if there is a thyroiditis, then what should be done? And just check it, go for the follow-ups and check what can be the situation. Acquired hypothyroidism in children and adolescents, acquired because of various reasons, and accordingly we can go for that. Again, you will find that in most of this levothyroxine is recommended, and if it is iodine deficiency, if it is simple goiter, then go for that. Check various reason, what are the reason, and accordingly go for the treatment. Okay, same is the case with the hyperthyroidism. You go for that depending on the, first you check the causes and accordingly go for the treatment. There are drug induced thyroid diseases, example amiodarine causes, the drug which are having high iodine content, it is there, and that particular should be treated with the high dose carbamazole, 40 mg per day or its equivalent. Okay, so this AIT means amiodarine induced thyroid disease. So this type 1, if it is there, type 2 AIT should be treated with the corticosteroids, and 40 mg should be given once daily for 2 to 4 days. Carbamazole and corticosteroid should be used if the patient fails on the monotherapy, because if it is because of the more accumulation of amiodarine or iodine, actually it is there. Will not go for ophthalmic impact of it.
श्वेता की एग्ज़ाम हुई थी ना, ये लॉकडाउन में अपन एग्ज़ाम दी थी अपनी HCP,
अच्छा
उनको मार्कशीट नहीं मिल रही है,
अच्छा,
तो अभी मंगाया है फिर से, तो आप साइन करो, फिर मैं सील करके भिजवाती हूँ यूनिवर्सिटी। आप ध्यान कितनी प्रैक्टिकल की लॉकडाउन में सप्लीमेंट्री एग्ज़ाम दी थी अपन ने 3 बच्चों की।
बैठो ना, बैठो। दो मिनट मेरे पास होगा ना इसका।
नहीं सर, नहीं घंटों में करके गया ना, क्या ये नाटक
मैं परेशान हो गया।
वो लड़की को, इसी में तो बोला था आपको, याद है? सबसे परेशान है 2 साल से।
इतने सेम थे ना?
तो साथ लगाएंगे। अभी मैं मोरे सर के देती हूँ साइन। एक एनवेलप मिलेगा आपके पास, मैं इसके नीचे से लेती हूँ।
इसके पास है।
हाँ? नीचे से सी रिसेप्शन से लेती हूँ।
So this is the algorithms we have seen already. We have seen all this algorithm of diagnosis. So these are all algorithms are there. Accordingly, we can go for that. And as I told you, treatments are very few, and accordingly, we are going for various treatments. I'll be sharing this to you, where the algorithm for diagnosis and algorithm for treatment both are there for various kind of thyroid diseases. Okay, if you have any difficulty, you can ask about it. Already I told you there is no big thing about it, and the treatment options are very less into this. So you go through this. If you have any difficulty, you can ask me. It's very easy comparatively, and there is no problem, I suppose, to understand. So take care about it. Then after that we shall go for the next classes. I want that you have gone through the various things related to because thyroid will be over. Oral contraceptive and hormone replacement therapy and osteoporosis. All these three are related to the particularly female sex hormones. So please go through these female sex hormones, all the actions and their pharmacology of these drugs by the next class, because I will finish all these three within 1 or 2 lectures if your pharmacology is good. Okay, if your pharmacology is good, if you have revised it, you will be able to understand it in better way. I think Navle sir has taught you this topic, endocrine. So go for that, read physiology of various female sex hormone, estrogen, progesterone, read various pharmacological agents of it and their actions and mechanism of action. Basically mechanism of action is same as the natural one. What are the synthetic and the natural analogues of it or semi-synthetic analogues of it, what are the effects or adverse effects of it, and accordingly we'll go for that. So read this thoroughly in the topic, particularly what we can say related to oral contraceptive, hormone replacement therapy and osteoporosis. Okay. Once this is over, then we'll go for the next topic. After that, in next week we'll finish this oral contraceptive, HRT and osteoporosis, maximum 2 or 3 lectures. But I repeat, for that the basics should be clear. Then glaucoma conjunctivitis, for that eye and structure you go for, you understand about it. For pediatric, you prefer whatsoever you want first. After this endocrine is over, if you want this topic 4, topic 5 or topic 6, any topic you can tell, 4, 5, 6, we will go for that. And you can just let me know. But for what you will need for that, let me tell you, that will help you to understand. See, oral contraceptive, I told you, all these are based, all these 3 are based on what we can say, the female sex hormone, that is estrogen, progesterone, their various effects on various tissues. So read physiology, read pharmacology. In that, in what is difference in physiology? In physiology, their normal activities are there. In pharmacology, there various analogues are there, which are available in market, synthetic, semi-synthetic, and the natural one. What are their effects? What are their indications? What are their adverse effects? Everything you have studied. I need a tabular form or any form assignment on that. Without assignment, I will not start, or I'll declare this as a taught then. Okay. So I need you can put on, those who are attending, only 13 student or only 11 student I can see here. So all this you will put on group, that this is the assignment which is asked. Okay. Then what next topic you want, whether you want general prescribing guidelines or ophthalmology or rational drug, whatsoever you want, accordingly we can go for that. Glaucoma already you have seen when we have seen ANS, but you can go through it again. Okay. Conjunctivitis and bacterial conjunctivitis, we shall go after that if you want, because recently we have studied glaucoma in ANS. Various anti-glaucoma agents we have studied in ANS during pharmacology. So please refer it. If you are going for glaucoma or ophthalmology, then I want that you have studied whole this anatomy physiology of eye. Then glaucoma you have studied in pharmacology, I want that you have studied it. Then next, if you are going for this pediatric geriatric patients, that is guidelines for, then your pharmacokinetics should be very good. I want that you have gone through pharmacokinetics again. So read the pharmacokinetics, and on that I'll ask some questions. Maybe I'll put this question for some marks which I may add into other activities. So here I want this, and only this rational drug, you need not to read anything, I'll explain you about it. So this is what we have to go for. Go through these topics, read it, and then we'll discuss what we should go next. Okay. Take care, read it thoroughly, and I need these assignments to be done by Monday, so that we'll start as soon as we get time, we'll go for this topic of oral contraceptive. Before that, by Saturday, I want the assignment should be there about pharmacology of drug acting on female female hormones or female sex hormones. So this should be given by Saturday. I think Aniruddha is there, Saba is there. You all please put it there. Aditi is there. You put it on group that this is the assignment which is required, and it will be marked. Okay. So if any difficulty is there, you can let me know. We can discuss it. Okay. Take care.